and we are having, let's say, 2 sessions. The first session, it will be about uveitis and mainly about infectious uveitis. And we are having 4 eminent speakers. They are going to give a small presentation. Then we will have a roundtable discussions about that. We are going to start mainly about with this the first speaker in this session. It will be Dr. Armando Olivers. He is an associate professor of ophthalmology at the University of Puerto Rico School of Medicine. He has been managing his island most challenging uveitis patient and education resident for the past 15 years after completing his uveitis fellowship under the guidance of Dr. Douglas. The Oliver is participate as an investigator at the multi-center uveitis steroid treatment trial and the study of ocular complications. And he is having a lot of educations and participating as a speaker in many places. So Dr. Armando, if you can start, please. Thank you very much.
Thank you so much, Dr. Lambry. I'm so honored for the invitation. Let me share my screen. Today, we're going to be discussing this very interesting case, which we titled Acer or Not Acer, an interesting case of otter retinopathy. These are my financial disclosures, which are not pertinent to this case. This is the case of a 56-year-old Hispanic, Black Hispanic woman who suffered acute vision loss of her left eye of 1 week duration. This was associated with a localized photopsia in the same eye. She had a negative review of systems. Her past history was that of a mild myopia. She had a negative PPD test, which was done for work a year prior, a history of also of arterial hypertension, some osteoarthritis. Her mother had cancer, however, there was no family history of autoimmune disease. Her social history was pretty much negative. However, she disclosed that she had a new heterosexual partner with whom she had had unprotected sex 2 months prior to presentation. The right eye was pretty much normal with the 20/20 visual acuity. In the left eye, her visual acuity was finger counting at 2 feet. She had a 1+ afferent pupillary defect and 1+ feature cells. In the fundus exam, it looked pretty normal. The right eye, she had a mild posterior staphyloma and some drusen. However, in the left eye, when we have a closer look, we know that there is this demarcation line here, superior to the disc. We order further workup, and in the fundus autofluorescence of the left eye, we see that there's this area of increased autofluorescence corresponding to the area of retinal involvement that goes all the way to where the demarcation line is. In the fluorescein angiogram, there's hyperfluorescence of that demarcation line, as well as some periphleboitis in the area of retinal involvement. The Icg test showed a geographic zone of hypocyanescence that corresponded as well with the area of involved retina. We got an OCT, which we can see in the right eye is normal. In the left eye, it showed some vitreous cells. There was also loss of the ellipsoid zone as well as some drusenoid deposits. So also, we got a visual field test. It showed a central scotoma with temporal extension in the left eye as well. So what are we thinking? This is a summary of what we have in this patient. And well, it seems the patient has Acer. That's what we're thinking. So, well, this looks like Acer. Wouldn't everybody agree? Well, Acer was first described in 1992 by Dr. Dungas, and it is characterized by things that our patients shared, like the localized photopsia, acute scotoma, a zonal loss of outer retinal function, scotomas in the temporal field. Patients may have an APD. They tend to be young females, and it has been documented to occur in Hispanics. It's also typically unilateral, as our patient had. Also, Acer tends to have this trizonal distribution where we have a zone of normal retina, a zone that's actively involved, and a zone of atrophy. And if we look closely, we can sort of demarcate those 3 zones in our patient as well. So we're thinking, well, patient, it seems like she has ASER. However, as uveitis specialists, we have to rule out secondary causes. So we ordered a workup. We must rule out syphilis, tuberculosis, and other things such as sarcoidosis. So we order a workup, and lo and behold, the patient is positive for syphilis. This is a game changer. We admitted the patient to the ward. We treated her with IV penicillin. We started oral prednisone, consulted infectious diseases, and we got a spinal tap, which was negative. And on the physical exam, she did have this maculopapular rash, which was characteristic of secondary syphilis. However, when we look at the different known or purpulent manifestations of posterior syphilitic uveitis, we wonder, where does our patient fit? And one might think, well, is this posterior placoid chororetinitis? The problem is that for acute syphilitic posterior placoid chororetinitis, you need a placoid lesion, and also although this condition is also associated with ellipsoid zone disruption, it's a little bit different. These patients tend to have a little bit more of anterior chamber vitreous inflammation. It's, as all syphilis, it can occur in HIV patients and people with neurosyphilis, but our patient did not have the plaque. When we look closely, this is a typical case of syphilitic placoid chororetinitis. We can argue that they tend to have a demarcation line, but that's almost always hypofluorescent, and her patient had a hyperfluorescent demarcation line, and she did not have a plaque. So what does she have? Well, she had syphilitic outer retinopathy. Thus far, 10 cases have been published in the medical literature. Our case has been submitted, and we performed a systematic review of the literature of syphilitic outer retinopathy, and we found that there had been 69 of 11 patients, including ours. It's characterized by ellipsoid zone disruption, which is found on all patients. They also universally have hyperautofluorescence in corresponding to the affected areas. However, in contrast with syphilitic placoid chororetinitis, in SOR, the fundus tends to be unremarkable. In these reports, 4 of the patients were noted to have a normal fundus, no changes, and 2 had very subtle RPE changes. And instead of having a full ocular inflammation, most of them, a minority of them actually had like some mild vitritis, 1+ vitritis. 2 patients had a demarcation line, which is a typical feature of ASER, just like our patient did. And what seems to be characteristic and differentiating SOR from ASER is the fact that in 6 of the patients that had an IVFA, 3 of them tend to have this IV periphleboitis. So that's one thing that seems to differentiate SOR from the non-infectious ASER. Mean age was 48 years. Some of them were HIV positive, as can be seen in syphilis. They all presented with blurred vision. Some of them had photopsias. Presenting visual acuity, 37% were worse than 2200, but 25% was better than 2050. And there was some affection of the visual field in most of the patients that had a visual field. We did not find a specific scotoma for the condition. However, the scotomas tended to correspond with the area of retinal involvement. The prognosis for syphilitic outer retinopathy seems to be good. 10 out of 16 eyes ended up with a 20/20 visual acuity, while everybody had at least 20/40 vision at the final visual acuity, which the final visit, which occurred at a median follow-up of 4 months. 4 out of 11 cases had a follow-up of over 1 year. 1 patient had a continued ellipsoid zone improvement with almost restoration of the ellipsoid zone by 18 months, and a patient had continued visual field improvement over 2 years. Now, as far as treatment, as with all ocular syphilis, this patient should be treated as neurosyphilis. Of course, the optimal treatment is IV penicillin, which should be given as 3 to 4 million units IV every 4 hours for 10 to 14 days. However, a recent study from the University of Washington, where they randomized 150 patients to either intramuscular penicillin or penicillin G, found no statistical difference between the 2 protocols for neurosyphilis. But I must note that they use a very strict protocol for intramuscular penicillin. They used 2.4 units intramuscularly every 24 hours for 10 to 14 days, plus they added probenecid at a dose of 0.5 grams orally 4 times daily. So that's a little bit cumbersome, but if they followed that protocol, they found no difference. IV ceftriaxone, some reports of SOR being treated, there are some reports of SOR being treated with ceftriaxone. However, that can have a failure rate which may be as high as 23%, particularly in HIV positive patients. Now, interestingly, adjuvant steroids were used for some of these cases. In 5 out of 11 cases, steroids were used. In 3 patients, the authors were thinking so much about ACER that they even started the steroids before making the diagnosis of syphilis. Interestingly, one of those patients had a visual acuity improvement from 2160 to 2032 just on steroids before any penicillin treatment. So that brought the question on whether immune mimicry may play a role in this entity. One other case had developed CME during the course of intravenous penicillin, and that edema resolved after a 5-week course of oral prednisone. So the author wondered if there was something like the Heidrich-Hertzmeyer reaction occurring in these patients. However, 6 patients did not receive any steroids, and they did beautifully. They ended up with excellent vision as well. So back to our patient, we treated her. This is the picture at 3 months follow-up. Her vision was back to 20/25. The demarcation line disappeared. She had restoration of the ellipsoid zone. Her on the fundus autofluorescence improved dramatically. We can see on the left the original one, and this is on the right, the last follow-up. Her fluorescein angiogram pretty much normalized. And on the ICG, we still saw some little remnants of hypocyanescence at a 3-month follow-up visit. However, she did well. So to conclude, the differential diagnosis of ASOR may include inflammatory and infectious etiologies, in particular syphilis. Physicians should always give syphilis in the differential of all uveitis entities. The role of steroids in syphilitic outer retinopathy remains undetermined. However, their use did not seem to be harmful. And all patients with ocular syphilis should be tested for HIV, as the condition share multiple risk factors and co-infection is common. I'd like to acknowledge my co-authors and thank you so much for your attention to this case.
Thank you very much, Dr. Armando. It's very nice and very excellent presentation.
Thank you.
There is a lot of questions, I think, but maybe after we hear all our participants in this, then we'll have around the table discussion. Ahmed?
Yes, no, I think that's great. I just have one quick question to Armando. So Armando, how we diagnose syphilis? What are the main, so for the audience, what are the main features that will make us think this is a syphilitic retinitis?
Oh, well, the thing is, it's in the differential of everything. So right. it's like a dogma for us uveitis specialists that we must test everything for syphilis. There, of course, there are some things that are typical, like toxoplasma. We see a focal retinitis next to a scar, then we might think that patient has toxoplasmosis, and like viral retinitis. There are some things that are so typical.
Syphilis, is there anything like in particular that would make you think this is syphilis?
That's a great question. I would love to answer yes, but responsibly I have to answer no, because I want everybody to think about syphilis all the time. So
but maybe if you have a
there's a pathognomonic feature, which are these small deposits on top of the retina in the whitish deposits. They seem to be pathognomonic in syphilis, but that I wouldn't tell them, like, unless you see that, don't order a test. You have to order a test for syphilis for pretty much all cases of uveitis.
Right, thanks. So yeah, we have the macular lesion and the saltpeter maculopathy as well. And
I think, Ahmed, if you allow me, if you want to discuss, we can discuss one by one, or at the end, which one you like better.
I was thinking one by one, but if you want to make it at the end, whatever
you want. As you like. If you one by one, so we can finish, because I have also a questions or a comment from dear friends here.
Yes,
Dr. Prasan, he is sending a comment. We have to talk. We have to think if there is to look for associated rash and bulbs and in bulbs and soles. This another things that we have to. But the main question is what is the history? Is the main things that tell us we have to think about syphilis, or whenever we are seeing any uveitis, we have to keep in our mind. So we need to figure out something that we can give this message to everyone here listening to us now. What is your comment, Armando or Ahmed or anyone of Fahad?
Yeah, Armando, go ahead.
Good evening, Fahad.
Yes, my comment is to test all uveitis patients for syphilis. It doesn't matter what the history is and how low your suspicion may be. We always order the test, at least in our part of the world. We order it for everybody because it's a potential curable cause of uveitis, and the least one would like to happen is to end up treating someone as having chronic autoimmune uveitis when they're syphilis positive, and that's something we can pretty much cure with 3 weeks of antibiotics. And if we don't rule that out, then we might end up treating something as the wrong condition.
And Fahad, do you do anything different?
No, just the same as Armando. So here in the UK, we always test VDRL in all of our uveitic patients, just because, unfortunately, syphilis is on the rise. But having said that, I don't hesitate or shy away from asking about any history of unprotected sex, because I think at least it gives you a high index of suspicion, and then you might engage the sexual health services to help you treat the patient. But as Armando said, that it can masquerade as any type of uveitis, so there's no harm, and at least if you identify it, you can treat this potentially curable and very treatable form of uveitis. The amount of times I've seen patients 660 to 6'5", and it's a miracle. So we owe it to our patients to identify it.
Thank you.
We have a comment, Dr. Teresa, Dr. Ahmed.
Dr. Teresa, go ahead.
Well, actually, it's a very interesting case. It's important to highlight how syphilis can actually have different phenotyping. Yeah. Thank you. It's a very nice case.
Thank you.
And just for me, there are certain lesions that will make you suspicious. Macular placoid lesion, the salt and pepper retinopathy in the macula makes suspicious. Vasculitis with retinitis like pigmentosa sectorial makes you suspicious. Uveitis with arthritis in a nail makes you suspicious. And always ask about men having sex with men, because most patients do have that, and also multiple sexual partners. Dr. Amri, any questions from your side? There's one here from Dr. Prashan Rao about testing.
Yes.
I think it's everything is mentioned already. Just I can write read for you a comment from dear friends here. They are participating. You need to check for TPHA, FTA, ABS rather than VDRL or RBR. Any comment about that?
Yes, I'd like to comment on that. It's a change in paradigm. Maybe 20 years ago, when many of us were studying, we would do a VDRL and RPR as a primary test. However, as in syphilitic uveitis, the sensitivity of a VDRL and RPR is 80%. So if we do those tests, we're going to have 20% of patients that are going to be false negatives. So we want to screen for syphilis in syphilitic uveitis. If we can, we should do both tests. But if we only have one choice, we should do a treponemal specific test, such as an FTA-ABS or a microagglutination treponemal test, as Dr. Prasen Rao has very well pointed out.
And Fat, quickly from you, in Europe it's the other way, right?
That's right. In Europe, we're still doing VDRL. But having said that, if you have a high index of suspicion, they will then do the more specific TPHA. But
the CDC just came up with this reverse screening a few years back. But as long as you know about that, that's good. I think, Dr. Amri, we move on to the next one. Are you okay with that?
Yes, please.
All right. So our next speaker is Dr. Fahd Kohel. Dr. Amri, if you would like to introduce Fahd.
Dr. Fahad, he's my dear friend. Dr. Fahad is a well-known friend of us, and many times he participates with us. He is a consultant ophthalmologist, Royal Halmstrim Hospital. I get difficulty to mention this town every time Fahad you comment about me. That's why I was waiting for Ahmed to continue, but he make me in a trouble. He feels you came. Okay.
The important thing, I'm in the UK. Amri, again, for always inviting me to participate in these meetings, and well done to him and his team for producing high quality webinars. And again, Ahmed Salam for his kind invitation for me to join this panel. So I'm going to just discuss two cases briefly. The first one is I've labeled locating the occult infection. And this is a patient who is 63 years old, presents with sudden loss of vision in the right eye with reduced vision. Left eye is asymptomatic, no history of ocular surgery or trauma, with a past medical history of a recent aortic valve replacement 3 months ago for aortic regurgitation. So with that history, my number one diagnosis or suspicion is of an endogenous endophthalmitis. His visual acuity was 360 in that right eye, 6.9 in the left, and he presents with a marked hypopyon, marked vitritis with no fundal view. This was his. This is the photograph from the front of the eye, and you can see a hypopyon with some synechia and diffuse hyperemia of the conjunctiva. This was the view of the fundus, and it's obviously hazy because of the marked vitritis. So again, our diagnosis was a right endogenous endophthalmitis secondary to a presumed endocarditis, and we thought the source was a replaced aortic valve. Although we suspected a bacterial etiology, given the rapidity of the history, I kept an open mind and treated this patient with intravitreal antibiotics and antifungals. And the antifungal of choice was the amphotericin B. We admitted him under infectious diseases. And obviously at the time of the intravitreal injection, we did a vitreous tap, and they covered him with systemic antibiotics. And he had a marked clinical improvement. And we started him on oral and topical steroids, 24 to 48 hours after the intravitreal antibiotics and antifungal agent. However, although his eye was improving, we weren't getting any closer to identifying the underlying cause or getting the underlying bacteria or fungus that was causing this infection. So serial blood cultures were negative. His vitreous tap was negative, which I repeated, which an echocardiogram, was normal. So although his media was improving, ocular media was improving, his vision was improving, 6/24, he was happy. He was still suffering pyrexial swings. So he was diagnosed with a pyrexia of unknown origin with increasing inflammatory markers, despite being treated with broad spectrum antibiotics and broad spectrum antifungal antibiotics. So infectious diseases doubted my actual diagnosis. They said, "Are you sure this is infectious?" I said, "Look, I don't know of anything else that's going to respond that well to intravitreal therapy, but also when I look at his eyes, I can see these, a couple of these fluffy lesions just above the vessels, and so therefore I suspect this is a fungal endophthalmitis." So they took on board what I said, and they actually did a PET scan. So a PET scan is a CT scan, but they use this kind of form of glucose that has a radioisotope. So they're able to pick up any increased uptakes of glucose. So it's very good at identifying focuses of infection or focuses of malignancy. And lo and behold, the PET scan showed an aneurysm, a hotspot, in the aortic arch. This is the axial CT scan through the mediastinum showing a saccular aneurysm of the ascending aorta. So essentially, this gentleman had an end arteritis, so an infection of the aortic arch wall. He underwent surgical excision of his aneurysm, and he had a microbiological cure with normalization of the inflammatory markers, with again further improvement in his ocular inflammation. And in the end, they identified aspergillus. So we went from a diagnosis of endogenous endophthalmitis to not identifying the cause either in vitreous tap or in blood culture. But because I stuck to my guns and I was very helpful to ID in giving them the confidence that this was an infection, they then requested a PET CT scan, which identified in the end the underlying fungus, which was aspergillus. So why use PET CT scan? It's a radioisotope and a glucose analog in which one of the hydroxyl groups is substituted by by fluoride group. Although it's taken up by cells, it cannot be metabolized, so it's unable to return to the blood circulation, so it accumulates within the cells, and it's more efficient across inflammatory cells. And very, very helpful in infection in identifying sources of fever of unknown origin. So if you have a true pyrexia of unknown origin, which is defined as a temperature of more than 38 degrees that lasts for 3 weeks and remains undiagnosed after 3 days in hospital, you can identify the source of infection in at least 62% of cases. So do recommend this investigations to your medical colleagues if you're confident you've got an endogenous endophthalmitis and unfortunately you're unable to identify the source. I think what I could have done differently with this case is not just entirely rely on blood culture. I could have sent a second tap for 18S and 16S PCR, which may have identified at least a bacterial or fungal DNA. And this is my. We'll discuss this case. Yeah, no problem.
Okay, can you get back to your picture, to the picture that you showed earlier? So this is patient with inflammation, and if you go to the second picture, to the fundus picture, and just dense fluoritis, and you cannot see anything. So how did you reach to the diagnosis that this is endogenous endophthalmitis? Because the patient was unwell?
It's purely because he didn't have a temperature at the time.
Right.
It was mainly because I had a high index of suspicion. This is somebody with sudden loss of vision, with no history of any past medical history, say like ankylosing spondylitis or any inflammatory disease that might give you a severe vitritis. But most importantly, he's had recent surgery or recent cannulation. For me, even if this could be inflammatory, I want to exclude infection, and therefore there is no harm with this severe presentation to do a vitreous tap and give intravitreal antibiotics. If it then doesn't improve, fine, you can change your mind and start the patient on a steroid. But if you miss the boat, if you don't act fast and intervene timely, this retinal will die, and he will have permanent disability, and you've missed the boat. So even if I was suspecting, say, this is a severe inflammatory vitritis, if I was unsure, no harm in treating it as an endogenous endophthalmitis in the immediate stage, and then it gives you a couple of days to then think about what else this could be.
Sure, that's a great point. So can you leave the fundus picture again, Fad? So maybe can I ask Therese here? So Therese, if you have this patient but there's no history of any hospital admission or surgery, how would you go with this case? So inflammation and just panuveitis, and you can can I direct that to Therese Fad?
Yes.
Okay.
Well,
Therese, how would you?
I would always be suspicious of infectious.
Right.
The sudden onset, the systemic history would always have to be in line with what I'm seeing in the eye. I cannot exclude the systemic history. I would seriously think of infectious with the hypopion and all. Yeah, I would think of infectious.
So would you still cover for endogenous endophthalmitis if there's no history, or you would cover for viral or toxo? Because it could be viral, toxo, it could be syphilis, or it could be bacterial. So what I'm just trying to reach to, how would you manage this case? There's nothing really contributing in the history now. If we remove the admission, how would you start managing this case?
If I'm highly suspicious of infectious, I would go for the vitreous tap and culture, and I would have the workup for the syphilis and the rest of the.
And what would you send the vitreous tap for? Bacterial and fungal as well?
Bacterial, aerobic, and anaerobic, and fungal. Yes, I would do this.
Okay,
and if it was toxo, I would actually have seen as an area of retinitis. It's not likely that we're going to have toxo with this severe vitritis without having a well-recognized area of retinitis within the retinas. I wouldn't think it's toxo. I would go with bacterial, fungal more than other infectious causes.
Yeah, even in the absence of a history of admission, just because of cover that, right?
The patient has been ill, and
no, if the patient, if the patient was not ill, let's say healthy patient. So let's go to Armando for that. Armando, if this patient is healthy and you have this presentation.
Well, I think I agree with Fahad. If you have a hypopia, you really want to do that tap and inject. And we've done studies here about the etiologies of our endophthalmitis, and we have a lot of fungi. So I would have also covered for fungi. And most likely I would have admitted the patient. If had I not had that hypopia, maybe I would have thought more about toxo and toxoplasmosis and viral. And I've done it many times. I just covered for those two entities prior to giving the patient any series or anything else. But here we have an hypopia. That's a game changer. I think you really, I agree with the tap and inject for that. More so when we have a definite vitritis there.
Yeah. That's great discussion, Ree. And
Ahmed, I think it all depends on the context. So that's why in our uveitis clinics we take our time to take this very long detailed history. So I've if I had a situation where somebody says, look, they sound HLA-B27, they sound like ankylosing spondylitis, they've had recurrent inflammations in the eye in the past, and this time it's just a big bad iritis, then I might be comfortable to try a steroid. If they have genital or mouth ulcers, erythema nodosum, and I'm thinking Behçet's, then maybe I'll start steroid. But honestly, if you have no idea and you have no clue and there's nothing in the systemic inquiry that gives you an idea, then that patient may be hiding the truth from you. They may be an IV drug abuser, for example, or there may be something in their lifestyle. There is no harm in just, go ahead and treat. And I mean, I'm no expert in septicemia, but I would imagine you can still probably get septic arthritis or any kind of infection without necessarily having to have surgery. So I think if you're unsure with a hypopen uveitis and a very bad vitritis and the systemic inquiry is giving you 0, the safest thing is to assume the worst, treat as an endogenous. It's interesting in terms of the TAP. In the UK, I can only send it as a culture. If I wanted to send for PCR, it tends to be the second TAP, unless I really suspect it's viral. But I think if money is not an option, I would send for culture, standard gram stain, culture, 16S, 18S PCR, and VZV and HSV.
Right. Thank you so much. The point I was trying to come to, just for the audience, the one listening to us, is how to think of infection. If there's no history suggestive of admission, one important thing here not to miss is herpetic retinitis. So that's the first one to cover, because everything else can wait. So viral PCR in a situation like this is very important. But if you have, as Fahd is saying, it all goes in the context and read what you're dealing with. You're dealing with a sick patient or intravenous drug use or history of admission, then you're thinking along the line of endogenous endophthalmitis. But if there is nothing in the history and you have a presentation like this, viral PCR is the first one, because it will not wait. The patient will be detached, or we have bilateral disease next day. This is great discussion. Thank you so much. Can you move on with your...
Ahmed, we have a few comments and questions. Yes. If we already are talking about the same...
yes, please go ahead, Dr. Muhammad. I cannot see.
Yeah, we are having also from a dear friend, also Dr. Prasan Rao, is the VR surgeon. Was there any association subretinal abscess, as aspergillus usually has an affinity to grow in the subretinal space? This is the questions.
This patient didn't. So once it's all cleared, he had a completely intact and flat retina. So this was just vitreous inflammation or vitreous infection, sorry.
There is also from Dr. Ashraf, he is asking also, he is suggesting I will cover virus and toxo till result come. This is his opinion also. If any comment about that.
Virus is the most important. Even toxo can wait, but virus free is the most important. You can cover toxo as well with medications. I don't know if any of the, I think that's what was said really, but virus is the most important, but it all goes with the history, as Fahd was saying. So it depends on what history. Here the history is very suggestive of, or at least makes you think endogenous endophthalmitis, the admission and aortic replacement, right?
One thing I do is I give these patients empiric therapy, and I started on clindamycin, ciprofloxacin IV, and also antiviral. So I'm covering pretty much everything. And also we do a lot of voriconazole, so we don't have any problems on starting them on empiric therapy while we figure out what's happening. And then when we give them clindamycin as a systemic therapy for endogenous, we're also covering covering for toxoplasma. So we usually cover for a whole lot of stuff when we treat them empirically while the cultures are out and the PCRs.
Yeah, Professor Lightman as well.
If the clinical presentation is not clear, so you'll try to give antibiotic, also antiviral and antitoxo till you get the result. Is this what
yes, we just go very broad spectrum to anything we can suspect, and then we start, as the evolution of the case evolves, we start narrowing down what we're dealing with. But really, we really don't want to miss anything, as Ahmed very well said.
Maybe the message is really like cover for the important ones, and if you can cover for all, I think that's an idea. Viral, and again, I think Fahd said it all. It's all in the context.
Of course.
Just remember viral retinitis. There was a question about the role of vitrectomy in fungal endophthalmitis. Fahd, do you want to comment on this quickly?
Yeah, I think that's a really good point. I think if your vitreous, so the two things I could have done differently is possibly when I sent the vitreous tap, sent for PCR, because maybe the 18S may have identified that this was a fungus after all. But the other thing is, if your vitreous tap is negative and you still suspect an endogenous, then I agree, doing a vitrectomy is a good idea, because you're getting the entire vitreous and the high load phase, and therefore your sensitivity is going to be greater. We know vitreous tap and vitrectomy, the vitrectomy sensitivity is better. I didn't do it in this case because he responded very well. His vision improved so much, I couldn't really justify a second operation.
Fahad, there is also a comment. Endogenous usually bilateral, but this patient is only unilateral.
No, I don't agree with that. I've seen a lot of endogenous that can be unilateral, yeah.
30% bilateral. So it's more unilateral.
So we can move to the next case, yes, please.
Yeah.
Ahmed, thank you for that. Mashallah, you know your stats. I'm quite impressed, actually, mashallah.
No, not at all.
Mashallah. So next case is 26-year-old male, 5-day red, painful left eye. He had previous eye problems when he was treated in India a few years earlier. So he was in the UK as a student, and he's now returned back to India. Sorry, I'll just move the screen out of the way. So his vision was 6.6 on the right eye, 6.12 on the left eye. Pupils were equal and reactive. Intraocular pressures were normal. He had a hyperemic conjunctiva, obviously 2+ of anterior chamber cells, 1+ of vitritis, with marked periphlebitis and cotton wool spots and venous reduplication in both eyes. This was the one of his color fundus pictures, and you can see this venous reduplication with some sheathing of the vessels. And like I said, a marked periphlebitis with the scattered retinal hemorrhages. And this is in both eyes, okay? But these magnificent venous loops and venous abnormalities. OCT was okay, although there is some distortion here, probably a reflection of some subtle macular ischemia. He has a fluorescein angiogram, and you can see there's a delayed filling of the infratemporal aspect of the macula. And then there's vascular leakage, confirming the periphlebitis, or vasculitis affecting the veins that stains in the late phase with disc leakage. And it's widespread. And there's obviously capillary shutdown. This is the left eye. And this is a wide field image showing widespread capillary shutdown with this macular ischemia and widespread periphlebitis. The right eye is less affected, but there is some shutdown in the periphery. So we suspected Eales disease. So we did mainly because of his racial heritage, because he came from India. So that was my number one suspicion. We sent a quantiferon gold, which came back as positive, and 90% of bilateral, but I didn't wait for that investigation. He had steroid pretty much within the first day of meeting me. Within a week or so, I was adding the PRP, and then as we were, within a week or so of starting the prednisolone, he was also started on mycophenolate. Once he had that quantiferon result, treated him for latent TB, and obviously because he's on steroid, he was covered with proton pump inhibitors and obviously calcium supplements. His vision improved to 6.6 with complete quiescence of his ocular inflammation. And my thoughts were, if I ever run into trouble, I would always consider intravitreal triamcinolone or anti-VEGF, but it never, thankfully, his condition never deteriorated where that was necessary. Long term, he was maintained on low dose of steroid and a high dose of mycophenolate, and visual acuity long term was good. With, by the time he left the UK to return to India, his vision was 6.6 in the right eye, 6.9 in the left. I do apologize to the audience, but I don't have any recent photographs to show the regression of his disease, but he did very well. Thank you.
Thank you so much, Fahd. So Fahd, can you take us through how did you diagnose that as a TB? So what's your differential diagnosis of vasculitis? And I know that it's because of the test and also the ethnic background.
So I think, at the end of the day, when you're making any uveitis assessment, and sorry to kind of spell the obvious, and I know I've got a very esteemed panel with me, but essentially what's the presenting complaint? What's their medical history? There'll be cues, and tell the patient to tell you everything. What medication have they been? Where have they been recently? Any recent unprotected sex? Any IV drug abuse? So this patient told me, I've just come back from India. Have you been in contact with anybody TB? No, but I didn't, because TB is prevalent in India. That was I didn't necessarily take that no as an answer. I then examined the eye. This gentleman has essentially a pan uveitis with a very good going periphlebitis in both eyes. Is this infectious? Is this non-infectious? So my infectious causes are going to be mainly TB, although I'm sure there are other things like Bartonella or, brucellosis, or not Bartonella, brucellosis, or Lyme, or whatever you can think about. But essentially, TB was going to be my number one infection. In terms of non-infectious causes, could this be sarcoidosis? And then obviously you always consider syphilis. But at the end of the day, it looked eels to me. That's what and also when I looked at his fluorescein, because of the widespread capillary shutdown and the retinal ischemia, that made me more think eels than say necessarily another cause. But having said that, keep an open mind. He gets everybody in my clinic gets a full blood count using these LFTs, chest X-ray, VDRL. I then do an ACE, quantiferon, and then I wait for the results. Because he's got no active infection, I also do a urinalysis to make sure there's no urine infection. I start him on steroid. I'm not waiting for TB to be confirmed or excluded. I think his chest X-ray is clear. I see him within a couple of days, he improves. Once that quantiferon comes back positive, I refer him to ID. But so essentially, and then the ACE comes back normal. The chest X-ray doesn't show bihilar lymphadenopathy, but I'm not waiting for tests to come back. And particularly with him, in this case, because that macula was not perfusing at all, I was concerned that he was going to have permanent branch retinal artery occlusion. So I was very anxious to start the steroid quickly. If he didn't have a retinitis or a retinal vasculitis, and it was, say, a vitritis or an anterior uveitis, I might be more relaxed and probably wait for the investigations before I go in with my treatments. Sorry for a long-winded answer, but I can't do it very short for you.
That's what we were
That's an amazing case.
How to reach the differential diagnosis, and that's beautiful.
Ahmed, we need just
there's a question about why Dr. Muhammad, go ahead.
No, we are short on a time, so we need also to be.
So maybe we move on to Dr. Trade.
Just we need one. There is one just a comment and from Dr. Ashraf. He say why mycophenolate.
Mycophenolate.
Mycophenolate for TB. Steroid is not enough.
It's a good point. Well, the thing is,
in a fast.
Okay, Afwan.
Sorry.
Very, very quickly.
Yeah.
Eels is not TB in the eye. Okay, it's an inflammation because there's TB elsewhere in the body. I could not get him below 10 milligrams of steroid without the inflammation recurring. I'm not going to keep him on high dose steroids long term, so I had to add in a steroid sparing agent. And in my mind, mycophenolate works really well for posterior uveitis.
Okay, there is another comment from Dr. Brasan. Also, he's asking, would you consider AKT or I think ATT with 4 drugs for 2 months and then the 2 drugs for 9 months instead of 2 drugs only? Is there another protocol, you know?
Yeah, I mean, I think that's a really good point. And I will bow to Dr. Rao's expertise on this, possibly because obviously he's trained in India or of Indian heritage, so he'll understand that they're the experts in TB uveitis. I can't comment. This was managed by the ID department, so that was the choice that they made.
Okay, Ahmed, you can go.
Yeah, Dr. Trace, please go ahead. So Dr. Trace Kamal is from Al Watani Hospital in Cairo, and she's a uveitis and medical retina consultant. It's a great pleasure to be with us. Dr. Trace, if you can please start.
Okay. I want to start by thanking Dr. Ahmed for inviting me to this very interesting and eminent meeting. I have 2 cases to present. My first case is that of a 40-year-old female patient who came with a history of systemic lupus for the past 10 years. She was complaining of decrease in vision in both eyes that started 1 month earlier with bilateral visual field defects that were progressive. She had history of CNS lupus 2 months earlier, and she had thoracic herpes zoster 4 months earlier. Currently, she was on Celsep 2 grams, steroid 60 milligrams. She was hypertensive, dyslipidemic, that wasn't controlled well, and she had also antiphospholipid positivity. Biocular exam, vision in the right eye and left eye were 0.05. She had normal eye pressure, minimal AC reaction of 0.5 plus bilaterally, and she also had a vitreous haze of 0.5 plus bilaterally. Looking at the fundus of the eyes, these are multicolored images of both eyes, and we can see that this patient has patches of retinitis from the mid-periphery spreading to the periphery with adjacent areas of intraretinal hemorrhages and severe retinal ischemia. Fluorescein angiography actually highlighted the severity and extent of the inflammation in the retina of both eyes, and we can see that the patient actually had severe ischemia. She had previous labs that showed high ESR and showed ANA that was high also. And thinking of this patient who has an autoimmune disease that has been long-standing, we, traditionally speaking, in differential of a patient with occlusive vasculitis, additionally, this patient has retinitis. Would we think of the non-infectious, especially that she's a lupus patient, or that she's an immunocompromised patient that might have an infectious etiology, which would be acute retinal necrosis, CMV, or toxoplasma, because we know toxoplasmosis can be confluent retinitis in immunocompromised individuals, and again, syphilis, as we have mentioned earlier in this meeting. Lupus could cause some form of retinopathy, but it could be either small cotton wool spots or peripheral retinal ischemia with insignificant inflammation. So likely this is not definitely the cause of the inflammation we're seeing in this patient's eye. However, she had several predisposing factors for CMV retinitis, apart from the clinical picture that we saw in the fundus. She was immunocompromised, she had an autoimmune disease, and she had received a cyclophosphamide for the CNS lupus that she had developed 2 months earlier. And this was actually the predisposing factor for the condition. So to me, this was bilateral CMV retinitis induced by cyclophosphamide. We had other labs done, and the CD4 T helper was found to be 38, which is extremely low, making her highly predisposed to developing CMV retinitis. I went on having an aqueous fluid PCR, which came back positive for CMV, and the treatment plan was starting both intravitreal and oral antivirals. She had ganciclovir bilaterally, intravitreally, and started on oral ganciclovir along with oral steroids of 40 milligrams daily. The patient received 6 injections in each eye, and we can see the right eye initially before the treatment, and this was after the patient had received a total of 6 injections in the right eye. The retinitis had completely resolved, leaving a ischemic retina with sclerotic vessels and variable hyperpigmentation. The fellow eye likewise after 3 injections, after 5 injections, and after 6 injections, complete resolution of the retinitis. And this was initially. So a few teaching points to our young doctors. Is the AC tap sufficient to be sent for PCR in patients with viral retinitis, or do we have to use the vitreous tap? Well, actually, studies have revealed that AC and vitreous taps for PCR in viral retinitis are quite comparable, and we can just settle for the AC tap. The role of systemic treatment is important because it would save the fellow eye from developing disease within 6 months in 60% of the cases. It would also treat the CMV viremia that the patient has, and we continue treatment typically for 3 to 6 months. And when the lesion has become completely inactive with increase in the CD count to 150. And the take-home message for this case was that infectious etiology should be considered even in bilateral uveitis, even if you know that this patient has an autoimmune disease. It doesn't have to be always related to, the uveitis doesn't always have to be related to the autoimmune disease. These patients are immunocompromised. My second case is a rather usual case. It's a 26-year-old
can I interrupt
patient.
you for 1 second? Just one
Yes,
question here. I think some degree would be of importance to discuss. Fahd, would you have used steroid in a case like this?
I wouldn't have actually. I because she's immunocompromised and it's a CMV retinitis, I have just managed them with either oral.
We'll have to move. We're after a short answer. We'll go back
Sorry.
to Trace. Armando,
I wouldn't have, no.
No steroids, definitely.
Okay, let me add.
What was your?
She was on steroids actually, and I tapered. She was on 60 milligrams when she came to me.
Oh, so you were tapered down. Okay.
Yes, because they were worried the CNS lupus should come back. Yeah. So I actually wanted to decrease it, and they refused. Yeah. So we had to just maintain on 40. But actually, yes, I am very,
60 beforehand, right?
I'm quite skeptical in viral retinitis to add steroids. It bothers me a lot. Yes.
I think in acute retinal necrosis, when the disc is affected, fine, but CMV just because immunosuppressed. But obviously, you were tapering down her steroids. Okay, well, thank you. Please proceed with your second case.
Okay, so in the second case is a 26-year-old female patient with decreased vision and complaining of decreased vision with floaters in the left eye that started 10 days earlier. And she had an unremarkable review of system. She was a healthy adult female patient. The left side that was affected showed a vision of 0.2 with slightly high pressure of 30, AC reaction of 1+, with vitreous haze of 1+, while the examination of the right eye, which was the normal eye, was unremarkable. She had imaging done a couple of days after she had developed the complaint, and we can see a small area of retinitis in the posterior poles. Forgive me for the images are not so good because she had them elsewhere and I scanned them. But by OCT, we have the typical appearance of the full thickness retinitis, which is very typical of toxoplasmosis. We have the Hork lesion, which is the outer retinal cyst that has also been described as toxoplasma, with a very small RPE hyperplasia that we can see likely the area where the scar was hiding. I had another fluorescein done when she came to me, and that was a few days into the ocular condition. And she showed areas of vasculitis nasally and temporally superiorly, which has also been described in toxoplasmosis. What's interesting, and I want to mention, is that the patient didn't receive any treatment, and we can see that the Hork has completely resolved. The retinitis is starting to decrease, and this is because, as we know, toxoplasma is a self-limiting condition. So I started my regimen, which is typically ceftriaxone, clindamycin, and oral steroids that I would start 2 days after antimicrobials and stop before the antimicrobials. And 21 days into treatment, the patient has started to develop the scar, the retinitis has resolved, and a small inner retinal cyst that we typically see in patients with healing toxoplasma retinitis. And a few days points in here is that would we diagnose patients with toxoplasma based on the clinical picture? Do we need to have serum serology, or do we always have to mandate ocular fluid tap and send for PCR or Goldman-Whitmer? Well, actually, if I have a patient with retinitis with a scar and the retinitis is localized, meaning the posterior pole, the patient is immunocompetent, and you can see the vitritis, I would settle for the clinical diagnosis and start treatment. Serum serology, as we know, is not always very yielding. Ocular fluid is an interesting part of this lecture usually, because ocular fluid PCR is less yielding than Goldman-Whitmer index in patients with toxoplasmosis, especially if the lesions are small, if the patient is younger in age, or if the reaction isn't very high. And so usually the Goldman-Whitmer would give better results than the PCR. Treatments in patients with toxoplasma usually wouldn't cure the infection. However, it can decrease the duration and severity of the inflammation, and thus decreasing the size of the scar. And of course, we have debates about if this would decrease the recurrences in toxoplasmosis.
Thank you, Teresa. We have to stop here if that's okay with you for the sake of time, unless you...
I wanted to move on to the recurrence, if you would allow me. The patient came back in 3 years developing recurrent attack, and we can see that the patient had a small extension of her lesion and 2 small lesions nasally. OCT showed that this patient had developed retinitis and also developed what's known as a punctate outer retinal toxoplasmosis, which are pick-like lesions that have been described in toxoplasmosis. And eventually, with treatment, they would heal completely and leave small areas of atrophy that could be site of recurrent inflammation. And we can see the OCT images after the patient received treatment for the second time. And in conclusion, toxoplasmosis could present in different phenotypes. Diagnosis could be clinical if it is classic. And lastly, treatment would depend on the regimen you would use, but usually it would not cure the condition. Thank you.
Thank you so much. I think we'll have to hand back to Dr. Mohammed for the anti-segment symposium in 7.
We have, Ahmed, 4 minutes if you have any questions, so no problem.
Okay, I can show a case
because
quickly.
It will be only 4 minutes, Ahmed.
Yeah, I know. So let me, and I'll hand back to you in 4 minutes. I'll show here a few thoughts, really. And Dr. Mohammed, please feel to stop me after 4 minutes. Okay, this is a patient where I was talking about, where you have panuveitis with vitritis, you cannot see anything. This is the differential diagnosis always to remember. Infection, inflammation, masquerade. And Fahad said it very nicely, really. It all depends on the context, but if you're not sure what's happening, the most important to cover is viral. So you give valcyclovir, you do a vitreous tap, and then everything else can wait. And this patient actually ended up being syphilis. So that's one way of doing it. There are some spot lesions. So here, for example, this is a unifocal retinitis in the posterior pole with arthritis next to a scar. That's an easy one. That's the toxoplasma retinitis. What about this one? That's again a unifocal retinitis, but there's no scar. Again, that's an easy one as well. That's still a primary toxo. So sometimes you have like spot diagnosis, and that's with artery occlusion. This one is hard to tell. It's in the middle. So is it toxo or is it ARN? Actually, it ended up being ARN. So that's here where you need to cover for ARN. You can still cover for toxo, but you need a vitreous or AC tap, because this one is really difficult. And that's actually ended up being a herpetic retinitis. That's a more classic herpetic retinitis. So peripheral, but when it's the mid-periphery, it's hard to tell. And always remember, retinitis is infection unless it's Behçet oral lymphoma. Yes. This is an Asian patient with chest disease, significant chest disease. And we were actually suspecting TB, and this patient had TB retinitis because of the patient's significant chest disease. He was also Vietnamese when I was in the UK, and in that population, TB is high, similar to East African population. Okay, this is a very interesting case. Here it's presenting with a progressing retinitis moving from the left to the right to down picture. and we excluded viral twice, and it's not viral, and you have this multifocal retinitis, and this patient is immunosuppressed. So the one thing to remember that actually toxoplasma retinitis can act very much like viral retinitis in elderly and immunosuppressed. And that ended up being a toxoplasma retinitis. So we told you toxoplasma retinitis is unifocal, but don't believe everything we say, because in immunosuppressed patient, it can behave as viral retinitis, and even in elderly patient. How many minutes, Dr. Mohammed?
Ahmed, if you don't mind, we can have a few questions to answer. Also, it will be, if
okay,
you don't mind.
Fantastic. And I think I just want to remind you of this differential and any questions to answer. Can you see any questions, Dr. Mohammed, we need to answer?
Yeah, there is a comment, so that we can just mention it, then we can have your comments, or dear colleagues here, Dr. Armando or Dr. Teresa. Also from Dr. Brasan, toxoplasma is generally associated with high IOP. How often do you see TB retinitis, as TB commonly involves the choroid?
Very, very not common. TB retinitis is not common. Usually you get choroidal lesion, or you get an appearance similar to TB delayed hypersensitivity, where was shown, or you get really an appearance of like an MP or serpiginous, but TB retinitis is not common.
Okay.
Are there any other questions? Or
there is one question from Dr. Ashraf also. Does oral acyclovir effective as like IV, I think, acyclovir?
Yes, it is as effective.
And maybe Trace wants to answer that. It's effective.
Yes.
It's the bioavailability is very high, so, and even they're using for systemic CMV. 900 milligram BID is the loading dose for 2 weeks, and then you go to maintenance dose.
Exactly.
Once a day.
I think, thank you very much for our colleagues here and friends, Ahmad and Armando, Fahad,
thank you so much
Teresa,
for
this very interesting session
Thank
about
so
uveitis. It needs more times, I know, but maybe next time we will give more than that. But today we are having another sessions, and we need to move to. Thanks a lot. Appreciate your presence with us.
Take care. Good night, everybody.
Good night. Thank you, Doctor.
You will be with us if you all want to join also with anterior segment. It's a very good also sessions. You can have a very nice share your experience.
الآن بنروح نفطر يا محمد.
Okay, no, not for you. I'm just joking.
we got fans to speak Arabic.
Guys, honestly, thanks for the invitation. I really enjoyed it.
I've
learned a lot. Thank you.
Just stop share, Ahmad, please. Thank you.
The reasons. Thank you, Dr. Amri. Okay. Thank you so much.
Ahmad, can you stop share, please? If you don't mind. Okay, thanks for the first sessions, and we will move to next sessions. It's the third episode of Cataract series that we are provided since now 1 month, and we are having still another 5 episodes. So today we will have a very eminent speakers that are going to participate in these sessions, and our one guest speaker and our friend also. We are happy that he is with us today, Dr. Khalid Abdurrahman Khalifa. He is a chairman and anterior segment consultant and of Expert Eye Center, Cairo, Egypt. He's a well-known figure in cataract and doing his techniques, and he is doing also many presentation about that, and we are very glad and happy to be with us, Dr. Ahmed. As usual, also our big boss, Dr. Yahya Salah. He's a well-known also cataract and refractive surgeon, and he is all the times with us, and he is the one who arrange these sessions by helping with Dr. Yahya. Thank you, Dr. Yahya, for being with us. Dr. Yahya also a professor of ophthalmology, Cairo University, Egypt. He is a consultant cataract cornea refractive eye care center, Cairo, Egypt. Also, we are having also our friends, Dr. Sharif Jamaluddin, professor of ophthalmology, head of cornea department, Cairo University, Egypt, consultant of cornea and refractive surgery, Dar Al Uyun Eye Hospital in Egypt. My friends, Dr. Usama Al Jaledi, consultant ophthalmologist, Moorfield Eye Hospital. He's a cataract and cornea and refractive surgeons. Also, finally, and my real and close friends, My brother's Dr. Safwan Al-Bayati. He's a consultant ophthalmologist, phaco-refractive retina surgeon, founder and medical director of New Vision Eye Center in Dubai. Thanks for all of you. And now we can move to our presentation. The first talks, I think it will be by, let me check. Who is Safwan? The first one is going to be?
Dr. Sharif Gamal. Dr.
Sharif. Okay, soft cataract. I think Dr. Sharif. Are you with us, Dr. Sharif?
Yes, Dr. Muhammad. Can you hear me quite well?
Yeah, we can hear you, but we are hearing a lot of sounds beside you.
Okay, I'm getting away now. I will start my talk.
So we are going to take today a lunch with dinner with Dr. Sharif. So, Dr. Yahya, which one you like to take?
Can you hear me now?
Yes, it's okay. Now clear, Dr. Yasir.
Okay, I'm going to talk today about soft cataract. And of course, this talk is dedicated to the phaco beginners. And my message to them is to catch the tips and tricks in order to perform well in their surgeries as they are going along the way. We all know that the grading of cataract is graded into 4 different grades. Grade 1, which is soft. Grade 2 and grade 3 lies between soft and hard cataracts. And grade 4, of course, is the hard cataract. So, the first thing that comes to your mind is soft cataract easy? And most of the beginners believe that soft cataract is easy. However, I differ with them because even though it looks easy, it is not. I myself fear soft cataracts more than hard cataracts, even nowadays. Why? First, there is no definite line between the nucleus and the cortex. They seem to blend with each other, and you cannot demarcate the line of safety between the edge of the nucleus and the cortex. Of course, when beginners start to start their phacoemulsification, they are happy by removing the nucleus as they go along with the phaco and eating parts of the nucleus from the front till the back, and they are surprised nearing the end by a layer of cortex, a layer, sorry, of nucleus that's formed like a shell. This shell nuclear fragment is very difficult to remove, and it endangers injury of the posterior capsule as you approach it. And this is one of the really difficult situations for phaco beginners in order to mobilize this nuclear shell and try to emulsify it. So, the soft cataract, what to do? There are 4 golden rules that we have to start while performing the cataract. Number 1, hydrodissection step is very important. Number 2, if you can prolapse the nucleus, it would be a good thing to start. You can perform the cataract using a single hand technique, and sometimes the chopper may help in performing the cataract. As I mentioned before, hydrodissection is very crucial in order to mobilize the whole nucleus together with the cortical material if possible. Because mobilizing this nuclear fragments or the nucleus will allow the nucleus to move freely and to come to the phaco instead of the phaco going to the nucleus which is fixed and not moving. But of course, hydrodissection has rules. You have to watch out for capsular block syndrome. And I'm going to show a little video how you can fall into a capsular block syndrome situation. It is not usual while performing soft cataracts or removing soft cataracts to suffer from this complication, But if you are not following the rules of hydrodissection, you can have a capsular block syndrome. What is capsular block syndrome? It is a large amount of fluid flowing by the hydrodissection step behind the nucleus, and the nucleus will rise fast up and block the exit of this flow, and will result in ballooning of the posterior capsule, and in the end, this posterior capsule will rupture. You might not notice while doing the hydrodissection that you have had this complication, but it can be noticed by experienced surgeons that you get a reverse shutter or a slight closure of the pupil, and then it widens back again exactly at the moment of the rupture of the posterior capsule. And while you are trying to perform phaco afterwards, if you have a big posterior capsule rupture, then you will end up with dropping of this nucleus. Here I'm trying to do the phaco. I did not notice as I was that I had the capsular block syndrome. And while I was doing the phaco, you will see now I'm trying to do sculpting, a divide and conquer technique in this case. And all of a sudden, this nucleus will drop into the vitreous. There we go. The whole lens dropped into the vitreous. The second thing that you have to take care of, or that you have to do, is try to prolapse the nucleus. If you do a little bit of excessive forced hydrodissection, the nucleus edge will prolapse, and this will make the phacoemulsification procedure a little bit more easy. As we can see, the edge of the nucleus has prolapsed into the anterior chamber, and this can allow me to mobilize the nucleus easier and better and emulsify with safety as I'm removing this soft nucleus from the away from the posterior capsule. In soft cataract, in my mind, I think that you can perform the cataract single-handed, not by manual, using a second instrument. You do not need to perform the cataract using a chopper or using a divide and conquer technique, as the nucleus acts like melted butter. You cannot divide the nucleus. It is dangerous to do grooving because you can easily injure the posterior capsule as you try to do divide and conquer technique. Chopping may be useful sometimes. However, it is not essentially needed. You can perform the whole procedure single-handed without the need for a second instrument during your phaco technique. This is a case of soft cataract, and we are revising here all the previous tips that I've mentioned. The hydrodissection procedure, the wave, we have to watch for the wave as it passes and avoid doing hydrodissection. We can prolapse as exactly we saw here. The edge of the nucleus has prolapsed into the anterior chamber. This will allow this nucleus to be mobilized easily, and I do not need a second instrument in order to aid in removing this nucleus. It is free floating now because of the hydrodissection, and it can be removed bit by bit. It's like a big irrigation aspiration port. The phaco here acts as a big irrigation aspiration port. Can we use a chopper in phacoemulsification? I believe yes. We can use a chopper in phacoemulsification. This is another case of soft cataract, but the chopper here does not divide the nucleus into parts because it's hard. It only helps in Although it is a soft cataract, but it can sometimes be divided and segmented in order to facilitate and avoid the blocking of the tip of the phaco while doing phacoemulsification. So a second instrument may be used sometimes, and I only advise chopping and not divide and conquer. You can use the second instrument sometimes in order to help you in dividing some parts of the nucleus, which in order to facilitate the phacoemulsification. Thank you very much.
Thank you very much, Dr. Sharif, for this very nice and excellent presentation and showing the complications and also the tips that and tricks that we need to know in handling or dealing with soft cataract soft nucleus. Dr. Safan or Dr. Usama, if there is any questions or any comments, any Dr. Khalid, Dr. Yahya, so we are having around 3 minutes to talk about.
I have one comment. I agree traditionally that we used to say that the soft cataract are not for beginners, but actually I teach my residents and my fellows that actually if we follow the proper technique, it can be the type of cataract that we start. What I mean by this is adding to what Dr. Sharif said, in soft cataract, you need to do only hydrosection or do hydrodelineation, actually what we call hydration of the whole capsular bag contents. All will be like an amalgam. Once you get this amalgam, it does, if it prolapses or if it does not prolapse, it doesn't matter. Actually, it's better to be inside the capsular bag. You will only need to use the phacoaspiration part of the phacoemulsification, which at that time is easier for a beginner. The other hand will only be used to feed this cortical amalgam into the phaco-tip. So this is my comment.
Just one comment also. If once you, as Dr. Sharif mentioned, once you started fragmented, and if you had the blade, it's always nice to use viscoelastic to push this blade away and forward to protect the posterior capsule. If that happened to you.
You mean to use viscoelastic behind the
behind the blade? If you form like a blade, it's always nice not to go too much with the phaco tip. Just use viscoelastic to push it forward to avoid to break the posterior capsule.
This is a nice idea. I agree with you. Although I usually don't need, but for beginners, I surely 100% agree with you, because this helps in keeping the posterior capsule away. Especially for beginners, they are not aware that the posterior capsule can quickly be aspirated. While aspirating the lens, they can come together. Although in the modern machines, this is a little bit difficult to happen, but yes, I agree, Dr. Osama. It's an excellent idea for beginners, of course.
Dr. Sharif, one comment is that I'm just concerned about that, whether the incarceration of the fluid behind the cataract when you're doing hydrodissection, it's in the soft cataract. And we saw that the nucleus wasn't so soft, because usually this complication happens in more harder nucleus. It's rarely can happen in soft cataract. So,
of course, I agree, Dr. Safwan, with you. You are absolutely right. It happens with hard cataracts. Yes, definitely. But you might be encountered. You have to watch while doing the hydrodissection. It's just to make sure that the hydrodissection step is done properly, using the right caliber, the right tip, and the right amount of fluid flow.
So my just point and comment here is that rotating the nucleus once or twice easily, the fluid will escape from the bag behind the nucleus, and you can prevent this complication. So when you have the jet in this obvious, because we are usually happy when we have this jet of fluid behind the nucleus, and we will continue, even we will do such a very small movement in the nucleus, but that's not true. Because this a very obvious jet of fluid means that there is a big collection of fluid behind the nucleus, and we need to rotate the nucleus clockwise and anti-clockwise to let this fluid escape from the bag. That's my comment.
Thank you, Dr. Safan. Thank you for all. Dr. Khalid, you have any comments? You are mute, Dr. Khalid. Can you unmute yourself? Sorry. Unmute. You are mute, Dr. Khalid. Okay, yes. No.
Thank you, Dr. Sharif, for the nice technique and presentation. And actually, Dr. Sharif is one of my mentors, and I learned a lot from him maybe 15 or 20 years ago regarding phacoemulsification. Thank you, Dr. Sharif, for the nice technique.
Thank you, Dr. Khalid. Nice to see you today. It's a long time.
Okay, thank you very much for all. Thank you, Dr. Sharif, for the nice presentation. Okay, now we will move to the second presentation by our friend Dr. Khalid. He will talk about how to deal and his technique in dealing with hard cataract. Dr. Khalid, the mic with you.
Yes. Now I'm sharing my presentation. Is it clear now?
Yeah.
Yes.
Okay, this is my strategy that I'm doing today regarding hard rock cataract. And first of all, I would like to thank Dr. Muhammad Al-Amri for the kind invitation to share my expertise regarding hard cataract. Really, I'm doing lots of hard cataract per year, and I would like to share how to save the ocular structures during the phacoemulsification of hard cataract. First of all, I have no financial interest regarding this presentation. We all know that there is many challenges in hard cataract regarding all of these capsular axis, the venules, corneal endothelium, and I would like to stress that preoperative endothelial cell count is mandatory in such cases, nucleus division, and the posterior capsule safety during the procedure. This is the spots we are caring during the hard cataract. First is the corneal endothelium, as I mentioned, and the posterior capsule, and the optic nerve, of course, and the retinal vasculature, and of course the venules, especially the subincisional part of the venules. Regarding the capsular axis, we all know the soft shell technique, which is injection of a dispersive OVD inside the anterior chamber, then pushing this dispersive OVD into the back of the cornea to protect the endothelium. But really, I'm not using this soft shell technique in hard cataract. I'm only using viscoat OVD, as viscoat is a bad pseudoplasticity, so that it will stay inside the anterior chamber for the whole of the procedure. And if I need to add more during the procedure, I may add. But because it has a bad pseudoplasticity, so that it will stay inside the anterior chamber, and even with some pressure over the wound, it will not move outside. And due to the shear motion of the capsular axis forceps during the capsular axis, it will not go outside, like methyl cellulose, which has a bad tendency to stay inside the anterior chamber, and at the same time the anterior capsule will be convex, liable for extension, and the same for the sodium hyaluronate, which has a good pseudoplasticity, so that it may go outside the anterior chamber with shearing effect of the capsular axis forceps, and also the anterior capsule will be a little bit concave, liable for small capsular axis, so that I prefer the viscoat during the capsular axis. Also, viscoat has adherence characteristics for the endothelium and the ocular structure, so that it will protect all the anterior chamber structures during the phacoemulsification. And here, this is the capsular axis. I usually start my capsular axis at the center of the anterior capsule, guided by the reflex of the microscope. Then I'm doing my capsular axis. In many of the hard cataract, I don't use capsular stain, as I depend on the difference of luster between the capsular axis and the underneath cataract, so that the capsule is shining and the underneath cataract is dim, so that I can highlight where is my capsule. And then I'm doing a sweeping of the cannula between the anterior capsule and the cataract, to have a cleft between both of them, to be able to insert my tuber after that, without doing a hydrodissection for fear of capsular block, as you just mentioned during the soft cataract of Dr. Sharif Gamaluddin.
Dr. Khalid, can you raise your voice, because I don't know, I feel a little bit
really?
Your voice.
My voice is not clear?
Okay, Safwan, can you mute yourself, please?
Unmute? It is unmuted.
No, you are okay, Dr. Khalid, but I'm okay, but I'm
okay. Now it is okay?
Yeah, now it's better, yes.
Okay. Then in the step of sculpting, the main problem during sculpting is to support the nucleus. Supporting the nucleus by passing the tuber between the anterior capsule and the nucleus equator to avoid excessive movement of the bag and to avoid any stress over the zonules, as I mentioned before, especially the subincisional part of the zonules. Second is the bottle height and the intraocular pressure in the new machines with the active fluidics to avoid any pressure over the retinal vasculature or the optic nerve, especially in hard cataract. The surgery may be a long procedure. Third is the vacuum level. I'm using a high vacuum to avoid any stopping of the pump. At this moment, I'll have a clouding of the anterior chamber so that I'm increasing the vacuum level during my sculpting. And here, this is how I'm doing sculpting. And as you see, the tuber is placed inside the equator or underneath the anterior capsule into the equator of the nucleus, supporting the nucleus, and then starting the my sculpting. The sculpting now is easy because I'm holding the nucleus so that the ultrasound is extremely efficient during grooving. And put in mind that my vacuum is high to avoid any clouding of the anterior chamber, especially with the balance step that it has a very and a huge stroke to be able to do this sculpting. Then I'm dividing the nucleus and exploring the posterior capsule to avoid any posterior polar cataract that may be encountered in such cases or any adhesions with the posterior capsule. Then Then the second part, which is the chopping of the nucleus, the main during chopping of the nucleus is to multi-slice the nucleus into many parts, as many as possible as I can with a horizontal tuber, and all fluidics during the chop will be fixed, as well as the ultrasound, as we are going to see now, and keeping the tuber inside the bag all the time. Here, this is because with this fixed fluidics and ultrasound, I'm going to sweep the foot switch between the last part of step 2 and the first part of step 3, because all my parameters is fixed. As you are seeing here, now I'm chopping the nucleus, all my parameters, flow rate, vacuum, torsion, ultrasound, all are fixed. The nucleus is very hard, so that I have to impale the tip very well inside the nucleus. If I fail in the start, then I go to another part. Don't insist to chop this part, go into another part and start to chop. First, impale the tip inside the nucleus, then go into step 2, the foot switch, and start to chop with pulling of the nucleus toward the center of the anterior chamber, and repeating this many times to have multiple pieces of the nucleus, chopping and chopping and chopping as possible as you can. Take your time to chop the nucleus even up to more than 16 parts. This will facilitate emulsification and will facilitate your goal with hard cataract. Here, don't feel that you are bored with dividing the nucleus. After finishing the first chop, then you will go. I'll go into a second chop, dividing the pieces that I did into smaller pieces, like what you are seeing here, putting the tuber at the equator and dividing the nucleus, holding the nucleus very well. Sometimes I lower the torsional ultrasound amplitude to be able to hold this part of the nucleus without emulsification and without aspiration, then dividing into more and more pieces of the nucleus. This will facilitate removal of these pieces, as you'll see during the emulsification. My goal during the emulsification of the nucleus is to have my emulsification inside the bag with bevel down, and second is negative vacuum rise. If you look here to this part of the display of the machine, you will see here, this is the vacuum rise. With adjusting my vacuum rise into a negative adjustment, this will help that during the machine accelerates the vacuum. Before reaching the full or the pre-adjusted vacuum, the flow rate will drop into 50% of the adjusted flow rate, and now the vacuum will not build up. Second, because the multi-slice technique of chop, I have small particles of the nucleus which will be aspirated very fast without building up more vacuum, and by this we will avoid any surge and we can emulsify inside the bag. as you are seeing here, now I emulsified my nucleus, and now I have small particles, and see how fast this smaller particles is emulsified without any fluctuation inside the anterior chamber. And here I'm tailoring my ultrasound to according to the revulsion of the nucleus. If there is too much revulsion of the nucleus, with this adjustment of the parameters, so that I lower my torsional ultrasound into a lower level. With this lower level, I may aspirate the nucleus very fast, as you see here. And sometimes, if I have a connected particles, I start first with this connection to emulsify. Then the nucleus will be separated into multiple fragments, which will be easy to be aspirated. Put in mind how the length of the tip is inside the anterior chamber, mainly inside the bag, as you'll see in the next video. And here, this is a connected part, so that I'm addressing this connection first to separate these particles from each other, and keeping the bevel down and aspirating inside the bag till the end of the last piece, not going into the anterior chamber, to be away from the endothelium of the cornea. And here it is aspirated, there is no occlusion and there is no surge, and I can be very close to the posterior capsule. And here, this is a side view, and you see how I am far from the corneal endothelium. This is the view to the left is the front view, and to the view to the right is the side view. And you almost hardly to see the tip of the phaco, because it is exactly inside the bag aspirating. You have to look into the front view to see that I'm aspirating, while in the side view you don't see anything, because the tip is hidden inside the bag, and everything is done inside the bag, away from the endothelium of the cornea, with the help also of this coat that's still coating the endothelium. Everything is away from the endothelium, and at the same time I have no surge because of the negative vacuum rise and the small nuclear fragments that will be aspirated very fast. There is no time to build up vacuum and to avoid any surge during the procedure. Finally, I wish that I give some tricks to help the audience regarding the hard rock cataract. And thank you again for your attention.
Thank you very much, Dr. Khalid. Always, as usual, very nice. Yeah.
I wish you heard me.
Yeah, no, we hear you very nicely. Thank you. And your presentation, as usual, excellent and very useful. I want to, before I give the mic for other friends for us, there is a tips for tricks that we need to learn from you, for me, for everyone that they are listening to us about the hard cataract. First of all, when you are doing, you mentioned so many tips, but for me, when you are holding the nucleus, I mean, what is the best way to make or to put the phaco tip so that you can fix it nicely and start shopping? This is very, very important, because we need, this is the first one. The second one, you like to do a shop, vertical or horizontal, I mean, in the hard rocky cataract. Which one is more easier, you think it will be to do that? Please.
Really, in my hand, I start to answer the last part of the second part of the question. In my hands is the horizontal chop is much more easier. But really, it needs a little bit more control, because I'm inserting the tuber at the equator of the nucleus underneath the anterior capsule, and this is a dangerous part, especially that you cannot see it. But what I'm doing is to impale the tip inside the nucleus. Then I pull the nucleus a little bit into the center to give room for the tuber to rotate around the equator of the nucleus, and then I'm chopping and moving both instruments against each other to be able to shop. Sometimes, if it is more hard than this, I may press some ultrasound to help during the fracture of the nucleus. I may press some ultrasound against the tuber so that both are moving against each other, which will help to shop the nucleus. And the best part to bot the tip is to know what's the bevel of your tip. If your tip is 30 degrees, so that occlusion is much more faster, just go into the nucleus, and at this moment you will hold very efficiently. But before chop, you have to go into step 2 of the foot switch, so that I'm adjusting all my parameters into fixed, just to move between the last part of step 2 of the foot switch and first part of step 3, just to do like that, not to push into the end of step 3, because if I'm at the end of step 2, I'll have all the fluidics to the maximum. And when I go into step 3, I'll get all my ultrasound to the maximum, because all are fixed or panel adjustment, so that I'm sweeping my foot switch between the last part of step 2 and first part of step 3, impaling the nucleus, then go into last part of step 2 and start to chop at this moment. I wish
yes, very clear, Dr. Khalid. There is, when you are doing separating, I mean, you are doing a shopping and you are separate the one you are doing, how far? Because sometimes, you know, if you go, because I saw you are doing it's this hard nucleus, it will be very big nucleus, it will be making a pressure on the venules. So how frequent you, I mean, how far you can do a separation to see? I mean, it's very, I don't know, it's very difficult to tell, but if there is any way just to not to do any harm or pressure on the venules.
First, we have to I have to tell that grooving is something different than chopping. During grooving, I'm supporting the nucleus, I'm holding the nucleus, so that my sculpting does not affect the subincisional venules, because I'm holding the nucleus. It will not run, and I'm not pushing the nucleus. I'm moving my tip inside the nucleus with ultrasound only. But during chop, splitting the nucleus and then separating, and I have to feel the consistency of the nucleus or the firmness of the nucleus, not to have that much separation, much force, but only my force is guarded, and I have to see what I'm doing. And if it's not separated till the end, I put my chopper a little bit down, and I may engage the nucleus again to separate up to the last part of the nucleus. But if it is difficult and there is no space to separate the nucleus, at this moment I leave it, and at the end I separate this, I emulsify this junction at first, then I'm addressing each part alone. And at the same time, I would like to say that I'm chopping the nucleus, the whole of the nucleus first, then I'm trying to emulsify, because keeping the whole nucleus inside the bag is much more easier to chop in such hard cataract, not to eat it piece by piece, because the last part during chop, it will move away from the tip, and it will be very difficult to chop at that time. So that finish the chopping first, then try to emulsify after that.
My last question before my dear friends, they have their comments. During, I mean, the separation of the nucleus, how far this is the, I mean, if we have sometimes a hard cataract, but a rubbery cataract, you know, you cannot, you feel that you are doing, but they are just going back together. Is there a way to overcome of that from your experience?
It was a problem for me when I was using a vertical chopper. But with a horizontal chopper, this chopper is a long chopper with a bulb at its end. This bulb will facilitate to separate this rubbery nucleus to the maximum. And as I mentioned before, if there is some parts still attached, I re-chop the nucleus and keeping that part attached to each other. And after that, I may inject a dispersive OVD viscoat under the nucleus to elevate this attached part above a little bit. Then I start to emulsify this attached part. At this moment, all the nucleus all the parts will be separated from each other.
Thank you, Dr. Khalid. Is there any question from Dr. Safwan, Dr. Usama, Dr. Yahya, Dr. Sharif? Yes.
A very nice presentation and very nice movie as usual. The issues is that first a few things. You mentioned, definitely you answered the first part, that the difficulties of Dr. Ashraf, Dr. Sharif, there's a lot of sound behind you. So you said that it's right when we are passing the chopper, that it's a bold end. That's right, it's a bold end. But when we are passing it between the anterior capsule and the nucleus to the equator, it's not an easy for the beginner. and it carries some risk, but you clean it you discuss it in a very clear way, that you are pulling the nucleus toward your side in a way that you are leaving a space or creating a space for this chopper to be. Now, the second question, you used a torsional power to create the chop. That's right. Your hand, it's very expert in that, and I know that you are using the torsional, and the IP was active, so means that there was a longitudinal and torsional. Do you think that for the beginner, the longitudinal for a chop is better than the torsional because it's more stable, fixed, in a way that it will create a fixed chop to hold the nucleus in a way that they can do the horizontal or a vertical? That's one question. Second issue is that starting with the longitudinal groove or excavation in the center, I feel in my hand, and here I'm doing personally a many hard nucleus. Excavation in the center, it gives at first it releases the nucleus from the hardest part, and it gives you a groove, an excavation that's deep, that you can hold the margin of this excavation and rotate the nucleus and chop the periphery. That's right. I do agree fully with you that both the grooving and excavation in the center, it can be easy for the beginner. In my opinion, is that it will be more easy for the beginner to hold the nucleus with excavation and using longitudinal power. I don't know what's your opinion.
I forgot the first question, by the way.
The first question you
just
the issues is that why you are using torsional power.
Safwan, can you just mention the question directly? I know you explained it already, just to remind him only.
You used a torsional power in chop.
And IP.
This is the first part, and IP was active. The second issue is that you are
Let him answer the first one question, Safwan, so he will not forget. Please, can we go first one by one? Yes, Dr. Khalid.
For chop, Dr. Safwan, with horizontal chop, you can chop with torsional phaco alone, or with longitudinal ultrasound, or with torsional and IP. I prefer torsional with IP because I like to have a small part or small cavity inside the nucleus, and this the longitudinal ultrasound will help me in the form of IP. But if I'm using longitudinal ultrasound alone, it will be enough. With horizontal, with the horizontal chop, I may use torsional ultrasound alone, because I don't need to embale too much inside the nucleus, except if I'm pulling the nucleus toward the center. This is the benefit of longitudinal ultrasound. But torsional may be enough, because I'm using two instruments against each other. I'm not using the vertical chop to press the nucleus down, so that I have to be catching the nucleus hardly to do a vertical chop. Horizontal is different issue. So the second question is the excavation inside the center of the nucleus. Yes, it will remove the biggest part of the rock material of the hard nucleus, but put in mind that supporting the nucleus at equator will give you the ability to use less ultrasound during this excavation. This is number one. Number two, that don't remove the whole part, the whole hard material from the center, otherwise the occlusion with the nucleus will be difficult at this moment, so that just keep a hard shell before the peripheral part of the nucleus to be able to impale the tip inside.
Thank you, Dr. Khalid. Can we have Dr. Usama? Yes.
Rather than a cavity, excuse me, Dr. Muhammad, just wait. We
need time, Safwan. We are already
in the center, rather than a groove. That's what I mean. It's only a tube in the center. It's not removing the whole hard part of the nucleus.
Yes, this is grooving. I'm widening the grooving a little bit, not to do a whole excavation or a pole excavation of the nucleus. Yes, Dr. Usama?
Which in simple terms, just stop and chop. Is that right?
This is a little bit, yes. It's like stop and chop, because there is groove at first, but stop and chop, you are doing 3 chops per half of the nucleus. But here I'm doing multiple slices of the nucleus.
So the modified part.
Yes.
Dr. Yahya, you have any comment or questions?
Yes, excellent, Khalid. Very nice technique. But I want to add one important comment for our colleagues, that the harder the cataract, the more exposure of the tip you should do. In order the exposure of the tip as related to the silicone sleeve, because this is the part which is going to impale into the nucleus. So this is one part. And in contrary, Dr. Khalid, I prefer always vertical chopping, because I can do it in any size of a pupil. I can do everything under vision. Third, I don't believe there is anything called rubbery nucleus. This is a term that we are used to say, but actually the reason for this, when it opens and closes, because you did not remove enough cortex to be able to separate. So the idea of Dr. Safwan, I do a technique called 2 nuclei concept. Maybe later on, maybe at another session we can elaborate about it. I do create the central part excavation, as Dr. Safwan was saying. Then you can see, when impaling and doing the vertical chopping, you can see the fibers and you can split it to the last fiber. So it will never come back as a pathology in the lens. It will come back only if you don't remove or split enough of the cortical fibers. But otherwise, the technique of Dr. Khalid is very well, and it's better that one can learn different techniques and to learn vertical and horizontal chopping. Sometimes you combine both in these difficult cases. And I agree with all the points Dr. Khalid said. Excellent presentation.
Thank you.
Thank you very much for all. We can move now to the last presentation by Dr. Yahya. He will talk about the intumescent cataract.
I would like to thank you again, Dr. Mohammed Amari, for his great effort in so many different educational platforms. And it's a lot of time, a lot of effort, and it's really a great effort that I would like to thank him for involving me in this. And الشاشة علقت. أنا عملت share, but nothing is coming out.
You can stop share and again. Yeah, now it's okay. It was already seen. Yeah, it's okay now. And
I thank also Dr. Safwan and Dr. Osama for their time to moderate different sessions and help us in their useful discussions. So thank you for them, really, for giving the time for this. So I'm going to touch on the intumescent cataract, the tips and tricks that we can talk about. Intumescent cataract types can be, you can see the cataract, the intumescent cataract in white cataract, which is a type of softer nucleus, or a brown cataract, where it's harder nucleus, or even black cataract. And you can face also intumescent cataract with shallow anterior chamber, like in intumescent cataract inducing secondary angle closure glaucoma, or hypermetropic patients with narrow pupil or pupillary block. So there are different, all they share in a main challenge that you really, none of us want to see this Argentinian flag sign. This is the main fear, the main difficulty in intumescent cataract. So all of us want to avoid this. Why? Because this will change the whole plan of the surgery. They increase the incidence or possibility of complications like opening posterior capsule, losing the nucleus, implanting a lens that we did not plan at the beginning to use. So it's the key in intumescent cataract is to do a proper capsular axis, and everything will follow afterwards. And many of the techniques we discussed earlier in Dr. Khalid's presentation will be helpful in removing the nucleus. But let's focus about the challenging capsular axis. Why it is challenging? Because there is no contrast. The capsule is stretched. There is high intracapsular pressure. So there are 3 things that makes the regular technique for us to do capsular axis makes it difficult. So how to avoid the challenge of ruining our capsular axis, or in other words, avoiding doing the Argentinian flag sign? So we can use the capsular staining, decompressing the bag to remove the second factor of increased intraarticular pressure, and then to be able to control the size and the creation of our capsular axis, so as, in other words, to convert the abnormal situation into a normal situation like we are used to do and follow the rules of capsular axis. So if we don't have the contrast, we can do capsular staining, and this we can use under air. Many people prefer this. I prefer using under viscoelastic. Whether any type of viscoelastic, some people will use viscocohesive or with Helium GV or Helium 5. That will help later on in the management of the capsular axis by balancing the pressure inside intralenticular. But whatever technique you use, it's you learn it and you use what you feel comfortable with. To create the capsular axis, after we overcome the problem of contrast, to create the capsular axis, we can use capsular axis forceps or micro forceps, as some people prefer this. We can use the needle cystotome, and recently we can use femtolaser, and some recommend doing a femtolaser capsulotomy in such cases. So there are so many different techniques to avoid this Argentinian flag sign or to get a continuous capsular axis, and it's very important to have a technique that you are comfortable with, that you can reproduce in such cases, so these cases that not put a challenge on you. One is the spiral capsular axis, where you start small axis and you move into circles until you reach the size if you want, and in this way it is controlled and it's avoid the sudden extension of the capsular bag. There is another technique described by Deepak and Bharati, which goes with a large needle. It's like 25, 23 gauge needle, puncture the capsule, aspirate some of the cortex, then do a small capsular axis followed by irrigation aspiration of the cortex to decompress the back, and then doing a snip in this small capsular axis and enlarge it to the preferred size. My technique is a little bit different. I prefer to do the capsular staining under viscoelastic. I swap it over the anterior capsule, and then with a 27 gauge, which insulin needle, straight, I puncture the anterior capsule, and then I do a curved tear. This curved tear is a very important trick, because if at any moment there is a gush of fluid that will tend to extend the capsular axis, it will extend in this way in the direction I want. Then I go out, I go with a cannula, 27 gauge cannula, like the helium cannula, and I go under the capsule, aspirate the cortex, and then inject viscoelastic and continue my axis, and I can repeat the step of aspiration as needed under vision. In this way, I control the high intraocular pressure, intralenticular pressure. I control the size and the shape of the capsular axis, and in a very reproducible technique that does not really take much time and does not take me into and out of the eye a lot of the time. This is sweeping under viscoelastic. I'm massaging over the. I don't need very intense stain, because it will appear. You see the curve here, the curve, and then injecting visco. Always trying to restore the rules, to equalize the pressure in front and behind the anterior capsule. Moving, stopping, injecting viscoelastic again, repeating aspiration as needed. You can repeat aspiration as you feel it's still in one area there is high pressure, and then you can control completely the size and the shape of the capsular axis in a very controlled and reproducible way. And this is very important. Again, just to repeat in a different way, massaging the stain, injecting viscoelastic. I just want the stain to be on the anterior capsule. Once you open it, you will see the contrast. Straight cystotome. You see the tape, the curve. So even if it needs to extend, it will extend where I want it. It will never cause Argentinian flag sign. Going with the cannula, aspirating and decompressing. Going out, injecting viscoelastic now to neutralize the pressure in front and behind the anterior capsule. I always like to work in high magnification because this gives me very good visualization and control of what is happening. Whenever you feel there is a possibility of extension, you just stop, replenish the viscoelastic. You can do this under any type of viscoelastic. And then you make it the size that you want. The harder the nucleus, the little larger the tip, the capsular axis needs to be. One important tip here, after doing the hydrosection, the capsular axis and bypassing the most difficult part, there is no need for hydrosection in such cases. By definition, it is already hydrodissected. And dealing with the nucleus thereafter depends on the density of the cataract. For the white is the easiest. And the hard cataract will be like Dr. Khalid was mentioning, and I'll just show this. You see, fluid gush with that curve, it didn't go out. I do all my cases under topical anesthesia. Sometimes you need to fix the eye with the cannula in the paracentesis. Whenever you see if it is going to extend, just stop, re-inject viscoelastic. It's very controlled. You can control the size. And then this is, I use Neuhan chopper. This is for the vertical chopping. This is a very brown cataract. I create a crater in the center so as I can see the depths, and then I crack. Everything is done under vision. You see the exposure of the tip, even it can be longer than this if it's harder. You impale the nucleus. You can see the vacuum is the main player. And I use the ultrasound very minimal. Ultrasound you will need it only to help aspiration and for impaling. And you see that vertical chopping gives you the advantages of seeing exactly what are you doing. And you cannot complete the case comfortably except if you have overcome the challenge of capsular axis. So the main challenge in intumescent cataract is to do a properly sized continuous capsular axis. Then you can use whatever technique you feel comfortable to deal with a white cataract inside or a brown cataract or a black cataract. The technique you feel comfortable, safe for the cornea and safe for the posterior capsule. So in conclusion, intumescent cataract is a special situation that needs a special management, and capsular axis is the main challenge in such cases. Thank you for your attention.
Thank you very much, Dr. Yahya. Very nice and excellent presentation, as usual. Okay, if there is any questions or comments from any of your colleagues to Dr. Yahya?
Yes, I have one. Dr.
Yes,
Yahya,
Dr.
usually
Yes.
the problem not during puncturing of the capsular axis, but sometimes in the periphery during fashioning the capsular axis, if there is too much hydrated cortex or lens fibers, at this area you may find the anterior capsule is elevated, and this is the site of escaping of the capsular axis. Do you have any trick to manage this area?
Yes, this is what I showed in the video, and I said, but it's a very good comment. Exactly what you say, you can have the pressure released inside from the center and at the puncture. And that's if there is this situation, I aspirate with the cannula. But as I said, when you go around and you see what you're saying, the pressure is high in the periphery, you just go with the cannula and aspirate again, and then inject viscoelastic and continue. So exactly what you're saying is very important thing, because if you feel safe only just aspirating in the center, then it can extend in the periphery, like you said.
So that the cannula can reach to the equator. Yeah, I'm reaching the cannula to the equator and aspirate.
But you don't need really.
Visible. Yeah, it should be visible, under visible. I'm seeing the tip of the cannula and
exactly
through that hole, especially at least 180 in front of me, lower, and try to remove. The lens matter is very easy to remove by this cannula, especially if it is, for example, let us say 25 or 26. I'm using 25 and 26 sometimes. An excellent procedure, Dr. Yahya. Sorry, Khalid. Yes, please.
No, never mind, Safwan. And I would like also to add, as Dr. Yahya mentioned in the Capsular Axis, that for beginners, methyl cellulose is the worst OVD to start with. Using let us to say a heavier OVDs is much more better and much more easy for the beginners to start Capsular Axis in such intumescent cataract.
Yeah, I advise them to soft shell, Khalid, here for the beginner, because soft shell, it gives more support, as Dr. Yahya said, especially even in staining. Definitely, Dr. Yahya is very expert in doing the staining under the OVD. But soft shell with the disintumescent cataract, it gives more support to deal with. And a second issue is that sometimes when you are seeing that the fluid is still keep coming and makes the whole anterior chamber opaque, so we will keep sucking the fluid and keep visualizing the tip of the cannula, because sometimes the tip of the cannula will drag or attract that part of the flap that we create and ending it, or it will be the source for the extending the anterior capsule.
Dr. Osama, if you have any comment, please.
Yes, thank you, Dr. Rahaz. That's very interesting. Yeah, just the only thing, the needling, you could use the same needling when you puncture the anterior capsule. You could use it at the same time to aspirate instead of take it out and take a syringe. Sometimes you can do it by the same needle.
Yes, and this is like the technique of DPEC, which I showed, but I use only the needle to make the cut and curve, and then do the aspiration. But of course, there are very good people doing this. Right?
The other things, if you press in the lens, it will allow some of the lens matter to reduce the pressure better. Just tap in the lens a bit, so to allow it to.
But you have to be careful that you have a curve. If you don't have a curve, it will do an Argentinian flag. And remember that not all intumescent cataract are the same exactly in the pressure inside them. So some will immediately extend.
Yes.
So that's why I advise for this curve when you make the puncture.
Yeah, it's care, but at the same time when you aspirate, you are touching a bit the lens, that's allowed to release more at the same time when you aspirate.
Dr. Yahya, but also sometimes when you are using the needle itself, just immediately when you just punch, it will lead to also to this Argentina flag.
No, it never happens like this. If you make it a slow motion for yourself, or if you see the videos of this, there is a point where you puncture and then there is a gap. Here is the decompression that will lead to the linear extension. But if you at the same time, because everything is still in the same pressure, when you make the puncture, you immediately curve the tear in the capsular axis. So even if there will be a gush when you are taking your hand out, then it will extend in the direction you want. It will never go to the equator.
Yeah, but what is the trick? How I mean, let us be more simplify the things. How do you do this, the curve immediately with a small, sometimes
yes,
it's when you are going to the puncture, immediately you will feel you cannot, it is only what I can say, few less than second, and you feel the things is going to be changed.
Exactly, but the whole thing is when you go and puncture, you have to go out. And going out, you just push the flap. You push the flap to make this curve.
I think
then
you can just run the movie. Tip is very important for all our audience and for.
If you can just show us again, Dr. Yahya, if slow motion, it will be more easier to learn.
But that's Mohammed. Also, it's nice to have inflate the AC well.
Yes, it's very important.
It's very important. Otherwise,
all the time you inflate.
Pressure. Yeah,
okay, but there is some
puncture Argentine flat straight away.
Okay, there is something else we need. Just I don't know. I'm doing this with my colleagues that we are not doing. A sideboard. Just we are using only before. Then we do the sideboard after that. Is that okay? Is that help also to maintain the pressure inside the eye while you are?
I don't think it makes a difference before you open. If you didn't open the anterior capsule, it doesn't make a difference. I don't know why it doesn't make me to share. Now it makes me share. Here. You see, this is going with the needle. You see, the curve is made now. You don't make a straight line. If you look here, already this is the curve in this area. So you didn't go out, so you didn't give time for decompression. Yeah, for the pressure inside to push it to away, to the equator. When you make this, even if there is a gush of fluid, it will turn it in the direction. You see here, you see the tear?
Yeah, it will turn it.
It go out. It's from the beginning.
Yes.
Then, you mean while you are doing the puncture at the same time, it's the same. You are rotating. You are not moving.
You're engaging and rotating it, creating the flap to take this curve. Once you do this, even if it extends, if you look here, it will extend in this direction, which is exactly what I'm going to do later on.
Okay, thank you very much. Is there any comment before we conclude our session? It was a very nice and excellent. We're already 2 hours and more. So thank you for all of you.
I have one comment, Dr. Muhammad.
Yes, Dr.
During aspiration of the liquefied material, what I found that the least OBD to be aspirated is the viscoat, because it has a very bad pseudoplasticity, so that its aspiration inside the cannula during the aspiration of the liquefied cortex is very difficult, so that it will stay inside the anterior chamber and it will maintain the pressure gradients between the nucleus and the anterior chamber.
So you advise to be used like a viscoat?
Yes, but exactly what Khalid is saying is correct. But on the other hand, I would like to say that for anybody working anywhere who doesn't have a special, there is not a special one. Some will give you advantage, but once you know the tricks, you can use any type of viscoelastic, but you can use viscoat, you can use Helon. It depends on your level, but at the end, all of them you can use if you follow the rules.
I think what Dr. Khalid is trying to say is to start with, it will be more better to have something that a highly viscose material that's available in the chamber and is not running out. So it will be easy to do the capsular access. Then maybe later, after you have an experience, you can change accordingly.
Exactly.
That's okay. Okay. Before we conclude, any last comments or anything from Osama, Safwan, Yahya, Dr. Khalid?
Thank you.
شكرا جزيلا للجميع.
Thank you very much for all, and have a nice, what can we say? It's morning already. We are in the second day in UAE now. We have passed the 12. So thank you very much, Dr. Khalid, Dr. Safwan, Dr. Yahya, and Dr. Osama, Dr. Sharif, and also for other speakers in the first part. And we hope to see you, inshallah, with another sessions in episode 4. Thank you very much, and good night. Bye-bye.
Thank you very much.
Bye-bye.
Thank you for the audience also. Thank you.
Yeah, thanks for participant, for the sponsoring company, for everyone. Thank you very much. Thank you, Osama. You are reminding me because I'm almost